Let's do some questions. So, following an emergency cesarean section for fetal distress, the consultant obstetrician hands the pediatrician a normal term male neonate. You note that the neonate is apneic, floppy, and blue in color. What should be your first action? What do you do? Administer atropine? What is atropine? Atropine is it a cholinergic? Anticholinergic? I'll search that later on. Initiate cardiopulmonary resuscitation. Is the baby breathing? Apneic. Oh, okay. So, yeah, probably you want to initiate CPR. Floppy and blue. Give 2 rescue breaths. Yeah, give 2 rescue breaths is the first step of CPR, I guess. Intubate and ventilate. As if they start breathing. Do you intubate before you do CPR? Apneic. Apneic, floppy, and blue. Is their heart beating though? I don't know. Dry the neonate. Probably have time for that later. It's not breathing right now, so drying is not the priority. Let's try. What? Dry the neonate. Okay. The first step in neonatal resuscitation, according to UK resuscitation guidelines, is to dry the baby. Remove any wet towels and start the clock or note time. The baby then needs a prompt less than 30-second Apgar assessment before proceeding to rescue breaths and cardiopulmonary resuscitation if necessary. The administration of atropine and intubation are much later steps in the management. Let's look at what's atropine. I already forgotten what that is. Let's see. Atropine indications in anesthesia to reduce the risk of vagal inhibition of the heart, to reduce salivary and bronchial secretions. In the treatment of cholinergic crisis in myasthenia gravis. So it's an anticholinergic, is it? In conjunction with neostigmine, used to reverse the effect of non-depolarizing muscle relaxants. What do these muscle relaxants do again? Oops. Okay, where were we? Therapeutic indications in anesthesia in conjunction with neostigmine used to reverse the effects of non-depolarizing muscle relaxants. I already forgot what these things do. I just studied this a few days ago. In the treatment of poisoning by certain cholinesterase inhibitors. Cholinesterase inhibitors. So there's too much acetylcholine activity. So atropine is an anticholinergic then. Let's look at pharmacodynamics. It's an anticholinergic. Atropine is an anti-muscarinic agent which competitively antagonizes acetylcholine at postganglionic nerve endings, thus affecting receptors of the exocrine glands, smooth muscle, cardiac muscle, and the central nervous system. Peripheral effects include tachycardia, decreased production of saliva, sweat, bronchial, nasal, lacrimal, and gastric secretions, decreased intestinal motility, and inhibition of micturition. Atropine increases sinus rate and sinoatrial AV conduction. I think that was a video by Speed Pharmacology. It's very good mnemonic ABCDs of anticholinergic effect. which I need to revise. So anticholinergics. Yeah, I think this is the one. Let's go.
Now, let's see all these steps in action. So in this video, I'm going to cover cholinergic antagonists. So let's get right into it. Cholinergic antagonists can be divided into three groups. First, anti-muscarinic agents. Second, ganglionic blockers. Third, neuromuscular blockers. So let's start with anti-muscarinic agents, also known as anticholinergic drugs. These agents block primarily muscarinic receptors, thus causing inhibition of muscarinic functions. One of the most well-known medications that belongs to this group is atropine. Atropine's primary sites of actions are the following: eye, GI tract, heart, salivary, sweat, and lacrimal glands. Now, anti-muscarinic activity of atropine in the eye results in relaxation of ciliary muscle, which causes dilation of the pupil, also known as mydriasis, inability to focus visually, also known as cycloplegia, and unresponsiveness to light. So, ophthalmic preparations of atropine are used before an eye exam or eye surgery, as well as to treat certain inflammatory conditions of the eye. However, because of its long duration of action, other anti-muscarinic agents such as cyclopentolate and tropicamide are preferred over atropine. While cyclopentolate and tropicamide can produce mydriasis that lasts for hours, atropine's effects can last for days. Another feature of atropine is that it blocks M3 receptors in GI tract, which results in reduction of GI motility from stomach to colon. This translates into prolonged gastric emptying and lengthened intestinal transit time. At higher doses, atropine can also effectively block M2 receptors on the SA node and AV node, which produces tachycardia. Heart rate may increase by as much as 30 to 40 beats per minute. Lastly, by blocking muscarinic receptors on salivary, sweat, and lacrimal glands, atropine produces dry mouth, dry skin, and ultimately causes body temperature to rise. The next very well-known medication in the anti-muscarinic group is scopolamine. So scopolamine, unlike atropine, has a much greater effect on the CNS, as well as longer duration of action. For that reason, scopolamine is one of the most effective medications used for prevention of motion sickness and post-operative nausea and vomiting. It is available in a patch formulation that provides effects lasting up to 3 days. Another medications in the anti-muscarinic group that I want to talk about are ipratropium and tiotropium. Ipratropium and tiotropium block muscarinic acetylcholine receptors without specificity for subtypes. This results in decreased contractility of smooth muscle in the lungs, which in turn leads to bronchodilation and reduction of mucus secretion. Tiotropium and ipratropium are administered by inhalation for maintenance treatment of bronchospasms in patients with COPD. Ipratropium also comes in a nasal spray formulation, which is often used for treatment of rhinorrhea, which is runny nose. The main difference between ipratropium and tiotropium is their duration of action. Tiotropium is a long-acting agent that is dosed once daily, while ipratropium is a short-acting agent that typically requires up to 4 times daily dosing. Another medications that belong to this group are used for treatment of overreactive bladder. These include tolterodine, darphinocin, solifenacin, oxybutynin, trospium, and fesoterodine. These agents have varying selectivity for the M3 receptor, which is the main receptor involved in bladder function. However, the overall efficacy among all of these is very similar. Last but not least, I wanted to briefly mention two muscarinic blockers, benztropine and trihexyphenidyl, which through their ability to suppress central cholinergic activity, were found to be very beneficial in treatment of Parkinson-like disorders. Now, before we move on to the next group, I wanted to make sure everyone watching this video remembers their ABCDs, which will help us to remember anticholinergic adverse effects, where A stands for agitation, B stands for blurred vision, C stands for constipation and confusion, D stands for dry mouth, and S stands for stasis of urine and sweating.
Okay, remember ABCDs. A stands for agitation, B stands for blurry vision, C stands for what? Constipation, D stands for dry mouth, and S stands for stasis of urine and saliva, sweating. Okay, let me see what I missed. Agitation, blurred vision, constipation, and confusion. So C has 2 components to it. Constipation, confusion. D for dry mouth. S for stasis of urine and sweating. Anticholinergics. Stasis of urine and sweating. Does it cause you to sweat, or does it cause stasis of sweat? Logically, if it is an anticholinergic, it has sympathetic effects. So it should cause sweating, right? Okay. Your ABCDs, anticholinergics. Okay. Where were we? The first step in neonatal resuscitation according to UK resuscitation guidelines is to dry the baby, remove any wet towels, and Start the clock or note the time. The baby then needs a prompt, less than 30-second Apgar assessment before proceeding to rescue breaths and cardiopulmonary resuscitation if necessary. The administration of atropine and intubation are much later steps in the management. Neonatal resuscitation guidelines. Birth, first dry the baby, then remove any wet towels and cover and start the clock or note the time. Within 30 seconds, assess the tone, breathing, and heart rate. Within 60 seconds, if gasping or not breathing, open the airway and give 5 inflation breaths. Reassess. If no increase in heart rate, look for chest movement. If chest not moving, recheck head position, consider 2-person airway control and other airway maneuvers. Repeat inflation breaths and look for a response. If no increase in heart rate, look for chest movement. When the chest is moving, if the heart rate is not detectable or slow, less than 60 minutes to 1. What's that? Less than 60 minutes minus 1. Start chest compressions with 3 compressions to each breath. Reassess heart rate every 30 seconds. Yeah, I think it's better if we go straight to the source, because it's quite confusing. What's this 60 minus 1? Resus. Okay. Guidelines: resuscitation and support of transition of babies at birth. Is this the guideline that we're looking for? I think so. So is it normal for babies? No, they should be crying when they come out. It's not normal if they're not breathing. So let's have a look at the guidelines. Sorry, we are going off on such a big tangent, but something to learn here. Is there an algorithm here? Birth, dry the baby. Oh yeah, okay. There's an algorithm here. Much easier. Birth, dry the baby, maintain normal temperature, start the clock or note the time. Assess for tone, breathing, heart rate. If gasping or not breathing, open the airway. It's all within 60 seconds, yeah? Open the airway, give 5 inflation breaths. Consider SpO2 plus ECG monitoring. Reassess. If no increase in heart rate, look for chest movement during inflation. If chest not moving, recheck head position. Consider 2-person airway control and other airway maneuvers. Repeat inflation breaths. SpO2 plus ECG monitoring. Look for a response. If no increase in heart rate, look for a chest movement. What's this? Okay. If no increase in heart rate, look for chest movement. When the chest is moving, if heart rate is not detectable or very slow, less than 60 per minute, ventilate for 30 seconds, assess heart rate. If still less than 30 minutes, start chest compression. Okay, so just remember the first thing you do is you want to dry the baby. Don't go straight to giving 5 breaths. You need to assess everything: breathing, heart rate. Then only if not breathing, give 5 inflation breaths. It's 5 inflation breaths, not 2. Over here it was the choice was 2, right? Give 2 rescue breaths. Supposed to be 5. Okay. And here's how you give Apgar score. Newborn resuscitation by paramedics. Oh, yes, quite the number of upvotes. Worth the look. The Apgar score is used to assess the health of a newborn baby. So there are 1, 2, 3, 4, 5 domains. Each domain can be scored from 0 to 2. So full Apgar score will be 10. 0 is the least. Apgar score. Is there a mnemonic for Apgar score? Apgar score. Okay, let's look at each of the components. There's pulse, more than 100 is a score of 2. Less than 100, score of 1. Absent, score of 0. Respiratory effort, strong or crying, score of 2. Weak or irregular, score of 1. And nil or absent, score of 0. Color, pink, score 2. Body pink, extremities blue, score 1. Blue all over, score 0. Muscle tone, active movement, score 2. Limb flexion, score 1. Flaccid, score 0. Reflex irritability, cries on stimulation or sneezes or coughs, score is 2. Grimace, score of 1. No reaction, score of 0. Remember there's a mnemonic for Apgar score. A for something, P for something, G for something. Let's see if it's available. A for appearance. So appearance is the color. P for pulse. Pulse is heart rate. G for grimace is irritability. A for activity, which is the muscle tone, and R for respiratory effort. Okay. Appearance, pink. Body pink, extremity blue or blue all over. P for pulse, right? More than 100, less than 100, absent. G for grimace or reflex irritability. Cries on stimulation, grimace or no reaction. A for, I got something wrong already, didn't I? Let's look again. Activity. No, so far okay. Appearance, color, pulse, heart rate, grimace, irritability, activity. The second A is for activity, just active movement or just limb flexion or flaccid. And R for respiratory effort. So strong, crying, weak, irregular, or nil. A score of 0 to 3 is very low score. Between 4 to 6 is moderate low, and between 7 to 10 means the baby is in a good state. Alright, let's have a look at this video since there are so many upvotes.
My name is Tamara Keith and I'm a paediatrician in London, and I'm going to give you a talk about neonatal resuscitation. So I'm hoping that at the end of this talk you're going to know how to assess the newborn baby, the sort of rules involved in newborn resuscitation, when you might think to intubate, and talk a little bit about borderline viability and when not to resuscitate. So why are newborns different from adults or older children? Newborn lungs at birth are full of amniotic fluid, and so we give inflation breaths to expand the chest to clear the amniotic fluid and oxygenate the lungs, whereas obviously in an adult they're already full of air and you're just trying to reoxygenate the lungs, but in a newborn you have to clear the fluid to then oxygenate the lungs. And chest compressions are more to move oxygenated blood to the coronary arteries to kickstart the heart. So the heart is structurally normal. You haven't got these blocked coronary vessels as you may have in an adult cardiac arrest. It's merely you're doing chest compressions to move the oxygenated blood to the coronary arteries. So at delivery, you're going to start the clock immediately, dry and wrap the baby, and stimulate the baby, and then assess the baby. And what I mean by stimulating the baby is really just drying the baby, giving the baby a bit of a rub, tickling the feet. Just the best way to resuscitate a newborn is to actually get it to just cry itself. So assessing the baby, you're looking at colour, tone, breathing, and heart rate. So if you look at this picture here, the baby is pink. You can see that the tone is good. They look like they're a little bit wriggly. They're clearly screaming, so they're breathing. And I can tell you that the heart rate in this baby was well over 100. So therefore, everything in this baby is good. You would merely dry and wrap the baby and give the baby to the mother. So with colour, you're simply looking, is the baby pale, blue, or pink? The tone, are they floppy or moving and wriggly? Breathing, is it present, absent, or irregular? And the heart rate, is it either absent, over 100, or less than 100? So you're not having to actually count the heart rate exactly. And then you come out with 3 categories really. The baby is either pink, crying with good tone, and therefore you do nothing other than dry and wrap the baby. The baby might have some irregular respirations, but have a good heart rate, and therefore you just need to help the breathing. Or the baby may be in a very bad way, being pale, floppy, no breathing, and a low heart rate. So a good situation would be as in this baby, was wriggling, so good tone, was pink, crying with a heart rate over 100. No resuscitation is required, and you merely dry and wrap the baby. Quite commonly, you get a baby who's not breathing, but with a good heart rate, so they may be a little bit blue around the edges, a bit floppy, and so you would open the airway and see if merely neutral positioning of the airway helps the baby to breathe. And you might need to give 5 inflation breaths, so these are slow breaths over 2 to 3 seconds, and they clear the fluid out of the lungs, and then reassess what your changes have made. So has there been a change with the colour, tone, breathing, and heart rate? A bad situation would be a blue, floppy baby who's not breathing with a low heart rate. And we're now going to talk about that situation. So with the airway, you need to obtain a patent airway in the neutral position. And the preterm baby may be unable to support their own airway, so you'd have to hold them in the correct position. You may think about suctioning, but this is only required if there's truly an obstruction, and you wouldn't ordinarily just suction a baby just because it's not breathing. It's not routine. So assessing breathing, if there's failure to establish regular breathing within 60 seconds, it's an indication to assist ventilation. So you would give 5 inflation breaths, and this is at a pressure of 30 centimetres of water on the machine, and a preterm would be a little bit lower. And the aim is to inflate the infant's poorly compliant lungs to clear the amniotic fluid, filling the alveoli with air for gas exchange. You always start resuscitation of the newborn in air, and this is to avoid oxygen toxicity. Ensure that the face mask is securely fitting the newborn's face, and there's no air leak. And you reassess the situation. So you're reassessing the colour, tone, breathing, and heart rate. If the heart rate is still slow, you need to ask yourself, did I see the chest expand with the inflation breaths? If the chest did not expand, you need to reposition the airway and repeat the inflation breaths. You do not commence chest compressions until you are certain there has been chest expansion with the inflation breaths. Are you in the neutral position? Is the airway open? Fill your airway and repeat the inflation breaths. You do not commence chest compressions until you are certain there has been chest expansion with the inflation breaths. Are you in the neutral position? Is the airway open? Try a one-handed or a two-handed jaw thrust. You may use an oropharyngeal airway, or you may need to clear an obstruction with suction. So basically reposition and try again. If the chest did expand, but the heart rate is still poor, and the baby is not breathing, then you need to start chest compressions. They're at a ratio of 3 chest compressions to 1 ventilation, and at a rate of 120. You continue the chest compressions to 120. You continue the chest compressions for 30 seconds, and then reassess colour, tone, breathing, and heart rate. Drugs are very rarely needed in newborn resuscitation, but are needed if there is failure to respond to chest compressions in 30 seconds. So if you're starting chest compressions, you need a member of the team to be getting the drugs prepared and getting the umbilical venous catheter ready. The drugs of newborn resuscitation are adrenaline, sodium bicarbonate, and dextrose. So now I'm just going to talk through that algorithm of resuscitation of the newborn. So first of all, you dry, wrap, and stimulate the baby. You assess the colour, tone, breathing, and heart rate. Open the airway, put it in the neutral position, and use a jaw thrust if necessary. Assess breathing, and if there's no breathing or inadequate breathing, give 5 inflation breaths. These are slow breaths over 2 to 3 seconds. Reassess the colour, tone, breathing, and heart rate. If the heart rate is still less than 60, ask yourself if the chest expanded. If it did not, you need to go back to airway, and reposition, and redo the inflation breaths. If the chest did expand, and the heart rate is still less than 60, you give chest compressions at a ratio of 3 to 1. After 30 seconds of chest compressions, if there is failure to respond, you move on to drugs. When might you need to intubate? So in a baby over 32 weeks, if its failure to respond in a few minutes with face mask ventilation, you may need to think about intubation. At less than 28 weeks, babies require intubation to administer surfactant, regardless of whether they're crying or not. Between 28 and 32 weeks, you may need some CPAP to support the ventilation, or intubate if there's no adequate response. We're now going to talk about borderline viability. So what I mean is babies who are extremely premature, those who are born at or before 25 weeks and 6 days. And this is approximately 0.28% of deliveries in the UK. So it's a very small number of deliveries, but nevertheless important. And there are certain rules about when you should help these newborn babies, when you should resuscitate them, and when you should not. At 25 weeks and above, resuscitation is started unless the baby is known to have a severe abnormality incompatible with life. At 24 weeks, the baby is offered full invasive intensive care unless the parents and clinicians agree that it's not in the child's best interests. If the child is judged to be more immature than expected at delivery, it may be considered to be not in the interest of the baby. At 23 to 24 weeks, the precedence should be given to the wishes of the parents. So resuscitation is not expected at this gestation and is only done if the parents really wish it to be so, and they need to have been counselled about the long-term expectations of a child at this gestation. At less than 23 weeks, so at 22 to 22 plus 6 weeks, you should not resuscitate the baby. Resuscitation should only be attempted if parents request it, even after detailed explanation of the likely outcome, which is likely to be death or long-term disability, and it is rare to offer resuscitation at this gestation. So in summary, we've talked about assessing the baby, colour, tone, breathing, and heart rate, algorithm of neonatal resuscitation, when to intubate, and when not to resuscitate. Thank you. And here's just the summary of the algorithm at the end for you to remind yourself.
Okay. Next question. A 42-year-old man with a history of alcohol abuse comes to your practice to discuss his recent diagnosis of chronic pancreatitis. You explain to him that his diagnosis puts him at higher risk of developing diabetes mellitus. What testing should you offer this patient in regards to this risk? So what testing do you do for diabetes? Annual fasting blood glucose, annual HbA1c, one-off fasting glucose, one-off HbA1c. I would choose the annual ones over the one-off ones because his chronic pancreatitis is not going away. Ultrasound of the pancreas wouldn't tell if you have diabetes. So it's either HbA1c or blood glucose. Which one is used for screening? I'm gonna go for fasting glucose. We'll see. The answer is HbA1c. So, diabetes mellitus usually develops many years following the start of symptoms of chronic pancreatitis. Patients with chronic pancreatitis are at very high risk of developing type 3C diabetes mellitus, otherwise known as pancreatogenic diabetes. Type 3C diabetes is caused by chronic pancreatitis in roughly 80% of cases and is more complex to manage than type 1 or type 2 diabetes. It is due to the concomitant exocrine insufficiency resulting in malabsorption and malnutrition. Diabetes mellitus may take years to develop following pancreatitis onset, and so the monitoring needs to be continued lifelong. This needs to be monitored long-term using annual HbA1c measurements. An ultrasound of pancreas will not give any indication of whether he has developed diabetes. It is also important that the patient is counseled regarding his alcohol misuse, as this may lead to worsening of his pancreatitis. No explanation of why HbA1c over fasting glucose. But I guess that's just the guidelines. Fasting glucose would also tell you whether he has diabetes or not. I mean, as a screening test. And would be cheaper to do than HbA1c. But then the patient would have to fast in the morning, which is... Do they have to fast for HbA1c? Probably not, because HbA1c is affected by your blood glucose level in the previous 3 months. Okay, so next time I know HbA1c is the one used for screening. A 72-year-old male presents to his general practitioner with back pain. He describes feeling a sharp burning pain in the middle of his back over the last few days. Sharp burning pain in the middle of his back. The pain is sometimes so severe that it wakes him from sleep in the night. He has experienced minimal pain relief with paracetamol, and he would like to be prescribed something stronger. He denies leg weakness, urinary incontinence, or numbness. He has no other medical conditions. However, he reports he was told he had an irregular prostate when he last saw his general practitioner 6 months ago. He remembers receiving letters in the post for further investigations, but he failed to attend these appointments. What is the most appropriate next step in the management of this patient? So what's causing his burning pain in the middle of his back? It could be that he has prostate cancer and then it has metastasized to his bones. And you don't want to just give painkillers to mask this. You want to investigate. However, it says there's no leg weakness, no urinary incontinence or numbness. All these are signs of cord compression that they are looking out for. So what's the most appropriate next step? Advise bed rest and for him to return to his return if his pain does not resolve. That's too conservative. Immediately refer him to the hospital for urgent assessment. I think this is one of the things to do. Prescribe stronger pain relief and advise him to refrain from gardening until the pain resolves. You're not addressing the risk that he might have bone metastasis. Repeat digital rectal examination and send an up-to-date prostate-specific antigen. Make a 2-week wait referral for him to be seen regarding his irregular prostate. I think in UK, 2-week wait referral is the main thing to do, because sending him to hospital in this case might not be the best step because he is stable. And you only want to give urgent hospital assessment if he's having some acute dangerous things like spinal cord compression. Oh no, I was wrong. The correct answer is immediately refer him to hospital. The reason being, thoracic pain is a red flag sign in patients presenting with back pain. Okay. Middle of his back. Okay. Red flag. The patient has several red flag features of his back pain that are concerning. These are its location, middle or thoracic back pain, its sudden onset and progression, night pain, and his recent prostate examination results. Together, these findings are highly suspicious for metastatic prostate cancer with spinal cord compression. This represents an oncological emergency and requires urgent hospital assessment. This finding are highly suspicious of metastatic prostate cancer with spinal cord compression. Really, spinal cord compression. He denies leg weakness, urinary continence or numbness. Where's the sign of spinal cord compression here? This represents an oncological emergency and requires urgent hospital assessment with magnetic resonance imaging of the whole body and treatment. Wait, explain to me again where is the sign of spinal cord compression? Sudden onset and progression, night pain, recent prostate examination results. These findings are highly suspicious of metastatic prostate cancer. Yes, that I get, but with spinal cord compression? Treatment with high dose dexamethasone. Maybe the thoracic back pain, rather than bone pain, is actually because the pain is due to irritation of your spinal cord. That's why they say spinal cord compression. Okay, this represents an oncological emergency and requires urgent hospital assessment with magnetic resonance imaging MRI of the whole body and treatment, high dose dexamethasone, and potentially radiotherapy and surgery. Any answer that does not recognize this as a clinical emergency requiring urgent assessment is inappropriate and therefore incorrect. Lower back pain. Lower back pain is one of the most common presentations seen in practice. Whilst the majority of presentations will be of a non-specific muscular nature, it's worth keeping in mind possible causes which may need specific treatment. Red flags for lower back pain: age less than 20 years or more than 50 years, history of previous malignancy, night pain, history of trauma, systemically unwell, for example, weight loss or fever. The table below indicates some specific causes of lower back pain. You have the facet joint. Facet joint may be acute or chronic, pain worse in the morning and on standing. On examination, there may be pain over the facets. The pain is typically worse on extension of the back. Spinal stenosis, usually gradual onset, unilateral, bilateral leg pain with or without back pain. Numbness and weakness, which is worse on walking, resolves when sits down. Pain may be described as aching or crawling, relieved by sitting down, leaning forwards, and crouching down. Clinical examination is often normal, requires MRI to confirm diagnosis. There's no mention about how this could be spinal cord compression. Oh well. Is there any discussion? Nobody. Never mind. Next question. A 27-year-old woman has been referred to early pregnancy unit with pregnancy of unknown gestation and with some pervaginal bleeding. She denies pain and is hemodynamically stable. This is her first pregnancy. Ultrasound demonstrates a tubal pregnancy, oh no, with visible fetal heartbeat and an unruptured adnexal mass of 40 mm. Beta HCG is 2000. What management would be first line for this patient? I don't remember the thresholds anymore. There's medical management and surgical management, I think. And depends whether the fetal heartbeat is there or the size or the beta HCG level. You would choose one over the other. Because there's a fetal heartbeat, I would opt for surgical. Either open or laparoscopic. Which one? I don't remember anymore. Reassure is definitely wrong. I think between the two surgical ones, laparoscopic will have better recovery. It's just that this mass, is it small enough to do laparoscopic? I think laparoscopic, and then if anything bad happens, you then have to open up. Let's see what's the answer. Yeah, the answer is laparoscopic self-injectomy. All ectopic pregnancies more than 35 mm in size or with serum beta HCG of more than 1,500 international units per liter should be managed surgically. So the threshold is 35 millimeters and beta HCG threshold is 1,500. Correct answer is surgical laparoscopic self-injectomy. I think there's a RCOG guideline for this. Let's have a look. Close. For what are we looking for? Ectopic. RCOG. Green top guidelines. Looking for an appendix. That would be very convenient. Too many words here. Oops. Appendix 3, contraindications. No, no. Table, no flow chart. Oh no. Let me see if they have a PDF version. It's taking quite some time to load here. You can access the guideline in PDF. Same thing, same link. Let's just download it for faster loading. Right. No, doesn't look like there's an appendix of flow charts. There was a table somewhere. Where did I see it? Probably a textbook. Man. Oh well. Management options. A laparoscopic surgical approach is preferable to an open approach. In the presence of a healthy contralateral tube, self-injectomy should be performed in preference to self-ingotomy. Women with a history of fertility-reducing factors, previous ectopic pregnancy, contralateral tubal damage, previous abdominal surgery, previous pelvic inflammatory disease, self-ingotomy should be considered. If self-ingotomy is performed, women should be informed about the risk of persistent trophoblasts with the need of serum beta-HCG level follow-up. They should also be counseled that there is a small risk that they may need further treatment in the form of systemic methotrexate or self-injectomy. Systemic methotrexate may be offered to suitable women with a tubal ectopic pregnancy. It should never be given at the first visit unless the diagnosis of ectopic pregnancy is absolutely clear and a viable intrauterine pregnancy has been excluded. Expectant management is option for clinically stable women with an ultrasound diagnosis of ectopic pregnancy and a decreasing beta-HCG level initially less than 1,500 microunits in international units. Too many words. Just remember that more than 1,500 units that you manage surgically. More than 35 mm surgical. Okay. Women who are stable are typically investigated and managed in an early pregnancy assessment unit. If a woman is unstable, then she should be referred to the emergency department. Investigation. A pregnancy test will be positive. The investigation of choice for ectopic pregnancy is a transvaginal ultrasound. Management. There are 3 ways to manage ectopic pregnancies, and the following criteria can help you guide you which method your patient will be able to have. So there's expectant management, medical management, and surgical management. Size of less than 35 mm, then you can do either expectant or medical. More than 35, you gotta do surgical. If it's unruptured, you can do medical expectant or surgical, but you can still do surgical after it has ruptured. If there's pain, then you have to do surgical. No significant pain, medical. Asymptomatic, expected. Okay, so when there's a fetal heartbeat, then you have to do a surgical. Beta HCG more than 1005, then you have to do surgical. Medical management is not suitable if there is a concurrent intrauterine pregnancy, whereas the other 2 is compatible if you have another intrauterine pregnancy. It makes sense because once you take methotrexate orally, it goes to the whole area, including inside your womb. Whereas in surgery, you can just focus on that fallopian tube which is affected. Or if you're not doing anything, it probably won't affect the other pregnancy anyway. And then the last difference here is expectant management involves closely monitoring the patient over 48 hours, and if beta HCG levels rise again or symptoms manifest, intervention is performed. Medical management involves giving the patient methotrexate and can only be done if the patient is willing to attend follow-up. Surgical management can involve self-pharyngectomy or self-pharyngotomy. So self-pharyngotomy is just cutting. Self-pharyngectomy is cutting and removing. In the cases where your patient has another viable fallopian tube, self-pharyngectomy is the preferred. But however, if you want to try and retain their fertility, if the other fallopian tube is blocked or already removed or not working, doesn't have an ovum there, then you have to try and do self-pharyngotomy to preserve her fertility. However, sometimes self-pharyngotomy might fail and then you have to end up doing self-pharyngectomy instead. Okay. Oh, there's nice health guidelines on ectopic pregnancy. Oh. Nice, does have guidelines. Let's look at the overview. But RCOG didn't point me towards nice. Does that mean that Green Top guideline is more up to date? It's November 2016. When was this updated? April 2019. So this should be more recent. So you have methotrexate surgery expectant management.